is so undervalued in obstetrics, and it really needs to be something that is taught to every single resident. Every single doctor needs to learn more about it.
Hey y'all, and welcome back to another episode of the Birth Lounge podcast. If you are feeling overwhelmed and unsure of where to turn to for evidence-based education around your pregnancy and birth, maybe you've just found out that you're pregnant and you don't really even know where to start. Maybe you're well into your pregnancy and you're starting to have questions, but you're having a hard time understanding what is honest, data-driven, science-backed education versus what is just viral and circulating on the internet. Then I want to introduce you to the Birth Lounge app. This is an app that is designed to put the control back in your hands no matter where you are in pregnancy. It's available for iPhone and Android, so head to your respective app stores and type in the Birth Lounge app, and you'll be able to download the app directly to your phone and access it anytime. So one of my favorite features is the week-by-week update of fetal development. And you know me, I'm not going to be comparing your baby to the size of a lime or an apple or a cantaloupe or something. No, I want you to actually know what's going on. When I say data-driven, I mean it. I want you to know, hey, this week you're growing kidneys. And hey, guess what? This week you're working on them ears, baby. I want you to know exactly what your baby is doing inside of your belly so that you can stay informed, so that you know no matter where you are in pregnancy, you are the decision maker. You have free will and autonomy, and you have access to data that will help you make the best decisions for you and your family. In addition to that week-by-week update of what your baby's actually going through, you're also going to find pregnancy and postpartum evidence-based articles. Now, these are going to tackle your most common questions. Should I really get tested for GBS? Why do we test for gestational diabetes? What is the science behind hiring a doula? Do I really need to write a birth plan? What is the best position to birth my baby in order to reduce my push times and decrease tearing? What are the newborn procedures that I should expect after my baby is born? How much should my baby be eating? How do I establish good breastfeeding? What about newborn sleep? Help, the umbilical cord fell off. OMG, I'm still bleeding and I don't know if this blood clot is too big. All of it is inside of the Birth Lounge. Not only do you get those evidence-based articles, but I link all of the data for you so that you can click on it. It's clickable links. I want you to be able to access the data that I'm talking about. You can just rely on me to synthesize it, but I'm still going to give you the resources that I'm sharing with you. And in addition to that, at the end of every single article, there are questions broken down that you can take back to your provider to ask them so that you can truly have this collaborative, respectful communication with them to make sure that not only are you getting evidence-based medical care, but that you're really building this really respectful, collaborative relationship and getting individualized care from your healthcare team. Head to your app store, whether you have an iPhone or an Android, and download the Birth Lounge app. I promise you it's going to be such a game changer. All right, on to today's episode. You guys know that preventing stillbirth is very important to me. About a year ago, I started my work with Count the Kicks and other organizations that really are spearheading the research in what causes stillbirth, how can we better educate the public on stillbirth prevention, and how can we start to educate our medical providers a little bit deeper on not only what causes stillbirth, but how they can support families who come to the hospital and report that their baby's movements have either drastically increased or drastically decreased, and how do we prevent providers from giving out outdated information like drink a glass of water or chug some juice and let's see if we can't get your baby to move. We all know that getting the data and the research implemented into hospitals and into practice can take many, many years. The data actually suggests that it may take up to 17 to 20 years. So I'm so excited to have an OBGYN on the podcast today who is really heading up this research and really being that push to encourage the medical community to look deeper in this. I'm very excited to be joined by Dr. Heather Florescue, who is a board-certified OBGYN practicing in Rochester, New York. Dr. Florescue is passionate about the prevention of pregnancy and infant loss and the care for families who suffer through these terrible tragedies. She is also the mom of triplets and overall just an amazing, amazing human. I thoroughly enjoyed my time having her on the podcast, and I learned so much. I'm very excited for you guys not only to learn from her, but to hear all of the wonderful data that she has to present, plus how you can be empowered to take these questions and this data and this information back to your provider so that if you notice anything different in your baby's patterns of movement, you have something to share with your provider and you know what your options are. So, without further ado, Dr. Florescue, welcome to the show.
Thank you so much for having me.
Yeah, absolutely. I'm so excited to have you. And I was telling you before we started recording that this is not a topic I've ever covered on the podcast. I just now have started to talk about loss and educate people on stillbirth.
For your viewers who have not been personally connected with stillbirth, I hope they listen to this entire broadcast. By listening to this, you are not increasing your risk of losing your baby. It is not something that you can catch. And while it's scary to hear about this terrible outcome for pregnancy, I hope that by listening to this and empowering people, that it could save your baby's life. So please, whoever listens to this, don't be fearful of what we're talking about. Look at it as a way that knowing about this, because when you talk to people who've experienced stillbirth, many of them said, I never knew this could even happen. So either they knew something was wrong and they weren't heard, or they truly did not know that baby still died. And they said if they knew that, they feel like it could have changed things. And knowing it doesn't make it more likely, it makes it less likely to happen. Education is power. And I think that's a really important thing for any pregnant person or somebody who loves a pregnant person who might hear your podcast is nothing we're talking about is contagious. In fact, it may be a preventative for you.
Yeah. To be completely honest, the stillbirth movement just came into my realm about a year ago when I learned about Count the Kicks as an organization. I had known it was an app, but I did not realize that there was an entire organization out there doing all this fantastic work. And knowing them led me to go into DC to advocate for stillbirth prevention within our legislation. And that led me to meeting the Measure the Placenta team, which led me to you. And so that led us here today. And I'm super excited to talk about almost like a futuristic idea. We have a little bit of data that tells us not how important the placenta is. We know that. Lots of
Mhm.
data tells us how important the placenta is, but specifically the size, the weight of our placenta, and what that may mean for the health and well being of our babies in our pregnancy. But the crummy thing is, there's not a lot of data about it. So before we dive into the data that we do have and the data that we don't have, can you start by just explaining what is estimated placental volume? What does that even mean?
So basically, it is a relatively simple way on ultrasound to measure the size of the placenta. You can start it really at 20 weeks. You can really do it all the way through. And then Dr. Harvey Kleiman created a app that is free to download. And so basically, you teach your sonographer how to get those images, and then you can measure the placenta really at any gestational age. One of the things that you're looking at is not necessarily the percentile, but actually the ratio is a really important thing too. A baby that is measuring fifth percentile with a fifth percentile placenta is a different thing than a baby who is 95th percentile with a fifth percentile placenta.
Can you
So,
explain those? What
yeah,
what each of those mean?
yeah, what we retrospectively know is that stillbirth is commonly caused by a placenta that is not big enough to be able to support the baby that it grew. So, and we don't know necessarily the reason for why that happened, but that you'll have example, a 9-pound baby with a placenta that was really meant to feed a 5-pound baby. And that, of course, makes pretty obvious sense that the reserve might be low. So when we look back at people who've lost their babies, we will often see that the ratio is very high. So baby to placenta ratio gets higher and higher. And as I said, we know that another risk factor for stillbirth is a too small of a baby, right? Those times you often see I've delivered some tiny babies and the placentas are equally tiny. And in that case, it may not be the size of the placenta and more some other things such preeclampsia or diabetes that affected the overall health of the placenta. It's all about the placenta. And I think that is one of the most important things is when we talk about stillbirth, especially term stillbirth, 80% are caused by things other than cord accidents. And unfortunately, we have a very strong notion that when a baby is born still at term, that it must have been that nuchal cord or it must have been something related to the cord around the neck, when in reality it's a placental based thing. And that is a missed opportunity to, even when we have a healthy birth, look at the next pregnancy and maybe prevent an adverse outcome. So you mentioned to me that the Shine for Autumn Act and going to get more research for that. We need placenta pathologists. We need more education and evidence about what makes a placenta healthy, what makes it not, and what is the risk of certain things for future pregnancies as well.
Are there theories about what might cause the placenta to have variations like this? Something that
Mm.
might cause a very small placenta with a big baby, or just a placenta that doesn't grow? And is that what's happening? Is the placenta just stopping growing, but the baby continues to grow?
I don't know that we've figured that out yet. Dr. Kleiman may be able to answer it more. He always says that placentas, they function well. So these are small placentas that are probably well functioning. But
Mhm.
of course, if let's say you have a patient with chronic hypertension, so they have high blood pressure, their placenta is not the same as the marathon runner without the chronic hypertension. So somebody who has this, they don't form as healthy a placenta. So they're going to get malperfusion in it. If that placenta is smaller than it should be, that may be a bigger risk than a smaller placenta in somebody who has no risk factors. So this is why prospective studies and why the Shine for Autumn Act is so important, because we just don't know. And we need to follow every pregnant person in this country and get their placentas and see what the outcomes are and really learn how do we figure out those babies at 20 weeks that are at risk for stillbirth, or what we're starting to term neonatal near misses. The baby is alive when it's born, but is coded and ends up in the NICU. those are babies that may have been passed away the next day. So there's so much, the is so undervalued in obstetrics, and it really needs to be something that is taught to every single resident. Every single doctor needs to learn more about it, because when we understand it, we can help our patients have better outcomes the next time, but also explain why outcomes maybe weren't ideal the first time as well.
Talk to us a little bit more about that. What does the placenta do? I've already mentioned, like, we know that it's really important. Why? What does it do? Help our audience understand, like, why the placenta is so important.
I think my favorite analogy to use with people is it's the gas tank for the pregnancy. So it is attached, obviously, to the wall of the uterus, hopefully normally. That can be a topic for another time. And it's an interchange between mom and baby. And there are numerous factors that create the healthy placentas and the less healthy placentas. And when we think about those gas tanks and how much reserve is in them, and we think about medical indication for inductions, almost 100% of those are gonna be because we know that placenta doesn't have the gas left in it that other pregnancies might have. For example, when you take chronic hypertension, the reason we're delivering sooner than the due date, ideally 37 to 39 weeks, is we know that gas tank may run out if the pregnancy continues longer. So that's why we do these medical induction recommendations. And just like in our hearts or anything else, this is a vascular organ, right? So it is based on blood vessels opening. It is based on vessels perfusing. So people who have issues underlying with their health of their vessels, unfortunately, are not going to have the greatest health in the placenta compared to people who don't have those underlying issues.
So it is truly the lifeline of your baby. So I have a question about valimentus and marginal cord insertions. Are we seeing any sort of correlation with that in stillbirth?
So there are a few things that will be associated, and there are probably things that maybe increase the risk of a cord accident potentially. Again, no prospective studies. So a lot of this is we just need bigger data and studies. But when the cord is marginally inserted, or even more concerningly, the limentous insertion, right? So it's not embedded into the placenta, it's actually dangling. When you think about that's gonna it yes, the gas tank's incredibly important, but what happens if the hose going to the baby isn't ideal, right? You're not gonna get that same level of great blood flow. That's the theory with this, but right now, even as high-risk OBs have not set a exact standard of how often should we be monitoring a filamentous cord insertion or a marginal cord insertion. The other parts of cords that we do know have increased risk of stillbirth is the coiling. So if they're undercoiled or overcoiled, those have been associated as well. But again, far and away, the more common thing is that the placenta, its health is just not where we want it to be.
If there's so little data behind it, I have a hard time saying it's not evidence-based, but right now we don't have the evidence to know that it's not evidence-based, because if we studied a bunch of placentas, we got the
Mhm,
data. It's
mhm.
possible that this would be a very evidence-based practice. It's not considered standard care right now. What do patients do? Are they supposed to be asking their doctors about it? Is this something that doctors are gonna be recommending? What does that look like with patients?
I think one thing that anybody listening to this can ask their doctor is, do I have medical conditions that may affect the health of my placenta? And when I was thinking about this podcast today, I was thinking about what are things that people should, in alluding to the health of the placenta, ask their OB provider. And I think the big things I thought about really were, do I have risk factors for a less healthy placenta? And if I do have those risk factors, what are things that we can do to reassure me that everything is okay with my baby as we progress through? We know that missing a fetal growth restricted baby has 5 to 7 times the risk of a stillbirth than not missing it. So this is a critical piece, I think, of everything we do when we see a patient for obstetrical care is, are they at risk for fetal growth restriction? Obviously a common precursor to stillbirth. And how do we not miss that? So sitting down with your OB provider and saying, are there things in my pregnancy that may affect the health of my placenta? And then I think a really important follow-up question to that is, should I be on a baby aspirins to help reduce that, help improve the health of the placenta.
What are some other risk factors that may lead to complications in the placental health?
Yeah, so there are numerous. Some are modifiable, obviously, some are not. The biggest ones, of course, as I alluded to, would be anything that affects vasculature. So kidney disease, lupus, diabetes, high blood pressure, I've said a lot of times. Obviously, this is more sensitive subject, but being obese is a risk factor. That's why it's a risk factor for preeclampsia as well. And again, that is not passing judgment, and that is simply saying, unfortunately, we do have good evidence that, especially for BMI over 40, there's an increased risk of stillbirth and complications. IVF is entering into that. Again, if you think about the gas tank, right? If the placenta is set up in a non-traditional way, all these early things that are happening may affect the overall health of the placenta, which is really interesting when you think about it. It's an embryo being put in is so early that can impact the outcome. But those are things, that we watch. Multiples, obviously, triplets, twins, higher risk. So there's many things, and I think it's a really important conversation to have. Another thing, which if you want to talk about the protocols in the UK and Australia, is smoking. Smoking, marijuana use is we're still trying to learn more about the marijuana, but really putting that in the same camp. If you think about it, smoking affects your heart, right? It affects your vasculature, and it makes it so your vessels aren't as healthy. So unfortunately, when people have smoking, which of course is an addiction, but that's going to affect the health of the placenta. And we do know that puts the baby at risk for things like growth restriction and unfortunately stillbirth.
And fetal growth restriction and IUGR, intrauterine growth restriction, are the same thing. Is that correct?
Yes, but I think we've moved. I don't ask me. I don't know exactly the politics for why we moved away from it, but fetal growth restrictions become the term for saying it. But yes, they are basically synonymous, and that's different than a 5 foot, 100-pound person when they get pregnant having a little baby makes sense, right? So
Totally.
so you can have a patient who has a baby that measures small the entire time, and you look at the patient, you're like, what was I expecting, a 9-pounder, right? Versus you have a 6 foot tall, robust person, and have a baby that starts at the 80th percentile, and then we see his percentiles dropping. That's a different thing. And so a baby that's chugging along because mom and dad are peanuts really is genetically makes sense. And things we can see on ultrasound to suggest that is, again, baby small all along, is symmetrically small. Its head isn't bigger than the other parts of the body. They're all uniformly tiny. When we see fetal growth restriction, same way as if we're losing weight or we're not getting what we need, we might actually lose a little belly fat. Our babies will do the same thing. So we'll see the abdomen get smaller. We'll see that percentile drop. One of the things when we talk about measuring the placenta and kind of what we're going to see, we need prospective studies for this as well, is the baby that is hovering in the 80th percentile, but then all of a sudden doesn't grow. For whatever reason we're watching, the baby doesn't gain appropriately in a time period between ultrasounds. Those are things that we're still learning more about, but to me say that placenta is not giving this baby what it needs to continue to stay growing.
When in pregnancy do we typically see that? At what point are we seeing that kind of stall in growth?
Mm. Very much it makes us very worried if we see it very early. So the earlier you see it, the more you're thinking about genetic conditions. So let's say we have a baby that shows up, everything's less than the first percentile at 20 weeks. You're thinking about chromosomal issues,
Mhm.
genetic conditions.
Mhm.
Later on, the placenta is when it's going to kick in. So even our theories about the placenta size and EPV, this is stuff that's going to kick in not at 28 or 29 weeks because the baby's still small. It's going to kick in when they get to term. And that's when you're going to start to see these things. So it's going to take time. The placenta is really good at what it does. It's unlikely to do this without extreme maternal health issues at 29 or 30 weeks. Or so we say then it's less than 32 weeks. It's just a very different bird than when you have the 39-week baby who you happen to scan and is now measuring small. So,
Yeah. Oh, man. Okay, so this is a little bit of a problem because we have this information. We know this might
mhm,
be a thing. It's not evidence-based. Providers aren't out here offering it to people. Maybe not the best thing to ask for our provider, but we have other questions that we can dig into. Our audience is familiar with monitoring fetal movement, count the kit.
mhm, mhm,
But you were sharing before we started recording that the UK and Australia are doing things really differently, and they have a lot more criteria of kind of checking in on your baby's well-being in addition to fetal
mhm.
movement. Tell us about that. What else can parents be doing to keep up with their baby's well-being still in utero?
Yeah, and we alluded to it a little bit before. The head of Scotland, who do like a whole medical chief officer, she's an OBGYN, and back in 2000, I think it was 9, she had as a resident this terrible experience with babies passing away, and she said, "You know what? I'm going to prevent stillbirth." And she actually created what became the UK Saving Babies Lives protocol. And then there's also Australia has Safer Baby Bundle. And the Safer Baby Bundle has 5 components to it, and we alluded to it a little bit, but the first component is quitting smoking, helping people quit smoking via carbon monoxide monitoring is one way you can do it, so actually having people see the carbon monoxide that they have as they breathe can help to get an idea of how that's affecting the flow into the placenta. They have lots of resources available. The second piece is making sure you don't miss fetal growth restrictions. Making sure, as said, having a patient say to their provider, and this is another thing that I like involve doulas with, is having the doula say to your patient, have you asked about things that might lead to your baby not growing well as they get into the third trimester? And are you somebody who should be on that baby aspirin or baby aspirins? And should you be getting ultrasounds? And just bringing that to your provider. The third piece is a sleeping time. So making sure that people fall asleep on their side in the third trimester. What we know is this position you fall asleep, you're going to spend the vast majority of the night in. Telling people not to panic when they wake up on their back, but just go back over to your side. And that is really something that we don't think impacts babies with really well functioning placentas. But we very much know that if the placenta is not functioning and is not as healthy as it could be, that definitely sleeping on their back is going to increase that risk for stillbirth and fetal growth restriction. So that kind of piece. The fourth piece, which is something I incorporate in my practice, we've incorporated most of this stuff in my practice already, is the fetal movement education piece, which we already talked about. And that's one of the components, but also how do we respond to when somebody is worried about fetal movement? Because right now, you can get a number of answers. I think the most important piece is that patients trust their instincts and they feel empowered to call. My biggest worry is that the internet, social media, unfortunately, family members, friends will try to invalidate their concerns, will not tell them to do what the right thing always to do, which is call your provider. There are many myths about fetal movement that they slow down, they run out of room, they don't move in labor, which all of those things really don't make sense, right? Why would your baby run out of room on Tuesday when it was moving fine on Monday? This doesn't make sense. So having these things out there and then having well-meaning family members say, "Oh, you're just being overly anxious, your baby's just sleeping," can result in tragedy. So we really want to make sure patients are well educated about it and then empower them to call. But we also need to make sure that when they're calling, they're not being invalidated by the office. They're not being told the myths by the office. And that they're this is a warning sign, and we know that decreased fetal movement is associated with adverse outcomes. And anything short of, "We'd like to see you and make sure that we evaluate you no matter what the gestational age is. We can do that appropriate gestational age," is a missed opportunity. And if we let's give the example, the 20-week baby that the mom says, "I was feeling him yesterday, I don't feel him today, I'm worried." We're not gonna save the 20-week baby, right? The 20-week baby can't survive outside. But when they call my office, they were brought in for that dop tone and to listen to the baby's heartbeat. And then they were empowered and saying, "We wanna hear from you again if this happens, because you never know If that 18-weeker gets told, I can't believe you're calling, you're only 18 weeks. When they're 39 weeks and worried, are they going to feel empowered to call? So we have a very dedicated from the UK and Australia protocol that we follow that evaluates the patient appropriate for gestational age, but also for risk factors. So if there's somebody at risk for it, checking the fluid, checking the ultrasound, all the growth, all those things, making sure that our patients always are empowered to call again. And making sure, which is part of the protocol as well, ask them if they're reassured by the evaluation. We know from retrospective studies that a gut instinct that something's going to happen, that something is wrong, has 24 times the risk of stillbirth. So the the pregnant person who comes in and is not reassured by the evaluation, has a gut instinct that something's not right, we want to make sure that we're doing everything we can to either deliver if they're ready for that or reassure them with future evaluation to keep them safe. So that's a big piece of these protocols. And then the final piece, which I allude to a little bit, is a conversation about timing of delivery, making sure that this is an earlier discussion and that this is something I always feel bad if I ever have to pull the rug out from under my patients. If you know they have a condition, a medical condition that necessitates delivery by a certain gestational age, explaining to them at 19 weeks, you have chronic hypertension, you're on medications. This means your placenta gas tank doesn't have the reserve that somebody who doesn't have this. So we're going to recommend, based on how you're doing, delivery by 39 weeks. That set at 19 weeks is totally different than the patient walks in at 37, 38 weeks, and we say, oh, by the way, this thing you've had since the beginning of pregnancy is now something that we're going to tell you we need to induce you. So setting that stage and making sure we are getting those medically indicated deliveries delivered. So timing that fetal growth restricted baby, timing their birth appropriately based on the size of the baby, those kind of things.
And if your provider's not saying this and you as the patient know that you have one of the things that Dr. Florescue has talked about previously in this episode, you can ask that question of,
Mhm.
hey, do I have anything that makes you concerned about
Yes.
needing to be induced early, my placental health, my cardiovascular functioning? Is there anything that you see that might change my plan at the end of
Mhm.
pregnancy that I might want to talk about now? That's amazing. Okay, so I do have a couple of questions based on what you were just telling about the Saver Baby kind of prevention bundles and the protocol. So when someone goes in and they say, I think something is wrong, fetal movement is down, whatever the reason is, what
Mhm.
does this evaluation look like? Let's say in this scenario, they were greeted really nicely and they took their concerns seriously, and now they're back in a patient room. What can someone expect?
So with this protocol, what we do is, so let's take their 34 weeks.
Okay.
We would always do the NST, just do that right off the bat at 34 weeks. So everybody who calls our office is going to get that when they're appropriate gestational age, which is why I said 34 weeks. And if they have a risk factor for stillbirth or fetal growth restriction, even if that NST is reactive, so it's showing us all the things that we want to see, the protocol says that we do an ultrasound, we check the fluid, the growth, and Dopplers if indicated within 24 hours. If it's not reactive, obviously we're going to be doing whatever we need to do. So our patient comes in, our nurse says, I hear that you're worried about this. They schedule the NST. If they see that they have risk factors, so I create a whole flow sheet that my nurses can pull up. They say, oh, it's your first baby, risk factor for stillbirth. We're going to do a growth ultrasound. We're going to check fluid. And after that's done, and my nurse is now 5 years out, they do this, they don't even think about it. They just say, are you reassured by this? And if the patient says, I'm really not reassured, then they bring it to one of us. And then they say to them, thank you so much for calling. It's so a message of you didn't bother us. You are not wasting our time. I joke around, my best friend's a dermatologist. So if you're ever interested in talking to a dermatologist, she's lovely. And she never works weekends. She never works nights. She works 3 days a week. And I always joke around, if I wanted to be a dermatologist, I would have been one. But I came an OBGYN because I love it. And because we love it, I know I'm going to be woken up at 2 in the morning. And that's okay. And the last thing I ever want is a patient afraid to call and something tragic happens to them or their baby. And I think one of the things that's so important when we talk about stillbirth and so many things is health disparities. And Black women are 2 to 3 times more likely to experience stillbirth. And I think when we look at care in general for people who are of BIPOC status, they are not feeling as empowered, right? They often express this, I wasn't feeling heard. I was, in terms of gaslighting, I wasn't being validated. One of the things I think, since we've implemented this in 2019 in our practice, is when this doesn't only make us validate the fetal movement concern, it validates everything, right? If my patients are always being validated when they call a fetal movement, it naturally translates to the, I hear you're worried about your head. I hear, and it teaches this mantra of, we care about you. You know your body and your baby better than anybody else. And we trust your instincts. And so why I want so much for what they're doing in the UK and Australia to be a national standard of care is I think it's going to address health disparities as well, because it really touches on that, right? A big critical piece of it is you have to ask the patient if they're reassured. And if we do that with every headache, every pain, everything that somebody comes in with, how much more are we going to catch the preeclampsia, the other things that might be going on, that the patient being asked a question and knowing that the provider cares about the answer, what can we do with that too?
Yeah, it's really, it does go back to like just listening to women, listen to your patients, and especially listening to those Black and brown voices. Because we know it's not just stillbirth that they are affected by, it's everything. If white people are affected by it, Black and brown people are affected by it more in every single category. One thing that I have learned by being in the lost community, these moms have taught me that many of them did know something was wrong
Mhm.
and they went in and they said
Mhm.
something's wrong and they were not listened to. It breaks my heart every time I hear it or every time I talk
Mhm.
about it because it is just so sad that we could have caught it. And it really, yeah, I think this is so super important for all the healthcare professionals out there
Mhm.
listening that when people say something's wrong, just look into it. And I had said this before we started recording as well, but the worst that happens is you say, okay, everything's good. That mom is
Mhm.
reassured and she wasted 2 hours of her day, right? And you put in an extra scan that didn't have to be. The best thing that happens is you listen to that mom. She was right and she's in the right place and we get that baby out. And now we have
Mhm.
a family that's
Yeah.
complete and not broken. Okay, another question I have is you had mentioned sleeping positions. Talk to us a little bit more about that. You had also mentioned don't panic, just get back on your side because I think a lot of people do have a lot of angst
Mhm.
about sleeping positions. What else do we need to know? And also, why would being on your back be compromising?
Yeah, so the reason why being on the back is compromising is that there's a major vessel that goes back into the heart, the inferior vena cava,
Hmm.
and you're going to put more pressure on that vessel when you lie on your back.
Yeah.
And that's why third trimester is when we talk about this, because the gravid uterus isn't doing as much prior to. So we always went for this left side thing. And the reason for the left side is that the inferior vena cava comes a little bit more to the right than the left. So it's not quite in our midline. And that was the reason for it. But really looking at sleep, it doesn't seem like it makes a difference. So you do not have to be on the left always. If you need to be on your right side, you can be on your right side. And then falling asleep on that side, when they've watched people sleep, they found that really the side you fall asleep in, the side you're going to stay on. So
Mm.
I never want anybody to panic that way. When we talk about sleep, another really important thing, and this is research that's really, again, not United States getting going as much as this is an Australia thing, is sleep apnea
Oh.
and how common it is in pregnancy. So obstructive sleep apnea. So the snoring that many pregnant people do, if your partner reports you're snoring, and especially if you have risk factors for it, like obesity, see if you can get evaluated for sleep apnea. We know that, again, if you're not breathing well, you're not getting that oxygen, you might not be forming that placenta as well. So when we talk about sleep, another important thing is if you're at risk for sleep apnea, your family history, you maybe snored before pregnancy, now you're snoring a lot, talk to your provider about maybe getting evaluated for that. There are studies showing that may reduce risk of preeclampsia, fetal growth restriction, and I think is really an important piece when we talk about sleep is if your sleep seems to be very interrupted by loud snoring, you're having fatigue, reach out to us.
Wow, that is so interesting. I knew this stuff about being on your back in the vena cava vein, but that is fascinating. I've never heard of the sleep apnea stuff. And
Yeah,
now
it's
just thinking about all the funny moments we've had in prenatals where
mhm,
partners have made fun of
yeah,
either person for snoring and it's like a big joke. And now I'm thinking, oh no, we
yeah,
there was an
and
education moment and we missed it. But now going forward,
yes,
where we know to
yeah,
say, oh wow, actually talk to your
maybe
doctor
should
about
be.
that. Yeah, ask
And
questions.
I I think you're also gonna see though that there's gonna be daytime fatigue, right? So if
Totally.
somebody's snoring because they're just will get congested in pregnancy and it's just like the nasal stuff, that's not as much as what we're talking about. But if I have a pregnant person come in who says, my husband says I'm snoring, I'm exhausted. I feel like I'm sleeping, but I'm tired all day. I'm having headaches. Those are the things where you want to prompt, is this something that could be sleep apnea related? And again, this is you and I were talking about, and you're saying you're new to this, the amount of effort that's put in to figure out how to prevent stillbirth, how to prevent preeclampsia, and everything related to this placental functioning is so in its infancy. But I think as we get 5 or 10 years from now, we're going to just get more and more when we say, again, talk to your provider and say, I'm having terrible snoring. Can we refer me for a sleep study? It's a relatively simple thing to do. It's a low to no risk test, right? And it can help you sleep better while you're pregnant and not be as exhausted. These are just again, it's having that dialogue with your provider of what can I do to improve my placental health?
Totally. Does exercise improve placental health? We keep talking about blood flow and
Mhm.
we're talking yeah, we should be exercising.
Yes. Oh, I think it's it's hard because we can only some people aren't able to exercise much when they're pregnant. So of course, if you're having pain limitations, any of those kind of things, but we know, which I'm sure you have seen as a doula, that people who exercise and gain appropriate weight and have less complications seem to have nicer labors and deliveries. We also see less preeclampsia for them. So we also see less of the fetal growth restriction. So as much as somebody is economically and feasibly able to do, taking walks, sitting on yoga balls, doing activity when you're pregnant, of course, anything that helps your heart pump and improve blood flow to the placenta is certainly a good thing to do while you're pregnant.
Nice. Okay, and I do want to circle back to the smoking. Is there a difference between people and I guess who are you talking about when we talk about smoking and getting these patients to quit? Are they smoking during pregnancy or are we talking about someone who has smoked at any point in their life,
Mm,
people who smoked up until getting pregnant? Is there a set number of months we know that you can
yeah.
quit smoking beforehand? How does all that intertwine?
So I'm not perfect with the literature on this, but I know that quitting before reduces by very significantly. So I think it's almost the same as if you're a non-smoker, if you quit before you're pregnant. But any point you quit in pregnancy has been shown to improve the outcomes. So it's going to be more robust in the first and second trimester. Remember, when we were like 14 weeks, that stage, that's where we're opening all those arteries and vessels and making that placenta. So quitting before you get to that stage has been shown to have less risk than if you're quitting later, but they see improvement all the way through. So remember, you're using that placenta like crazy during labor, right? Even if you've quit by the time you're in labor, that may help with oxygenation and perfusion. Again, totally recognize this is an addiction and that it's something that requires, it has nothing to do with how much somebody loves or cares and values their baby, but there are resources available. One of the things that's very important is if somebody is smoking in the range where lozenges or gum and stuff like that would be recommended, that half a pack plus amount per day. Yes, there's nicotine in lozenges and gum, but that's the only risky thing in it. And we have to remember that smoking cigarettes has far more carcinogens. It is okay to use those things when you're pregnant, and it's important to talk to your provider if you think that would help you quit smoking.
Definitely. I guess I have just an honest question. I don't really know anybody that smokes cigarettes anymore other than like older people. How many
Hmm.
people in the US are still smoking cigarettes? Is it really still a thing?
It is US wise, so it was 13% in 2006 and down to 7.2%. So right around 10% are smoking.
Yeah.
So
Wow.
yeah,
Okay. That's not a
It's a
small number of people.
No, it's not. And it's again, THC is now legal in New York State, and we need to be careful and make sure patients know that that vaping, all those things, that affects our lungs.
Sure.
So how does that, if we're not getting in the same amount of oxygen, how is that oxygen getting as well to the placenta? So remembering that really just because it's legal now doesn't mean, and we really need to figure out more THC, and that, at least in Rochester, seems to be on the rise since it, became legal. So,
Mm. Okay. I guess my final question about the protocol that we talked about is that aspirin. So we know that starting
mhm.
aspirin by about 16 weeks for preeclampsia, for people who have risk for preeclampsia, is what's recommended. Is it the same thing, or are we waiting until later? Are we adding aspirin once we find a problem? Is there a gestation where we're trying to get this aspirin into people that have stillbirth risk factors?
Where I live, we have studies that show the 81 milligrams that's available basically widely, that was shown to help prevent preterm preeclampsia.
Got it.
Studies outside of United States, when they look at into the hundreds, kind of 105 plus range, you start to see a reduction in term preeclampsia and potentially fetal growth restriction in stillbirth.
Wow.
Our local high risk OBs, probably about 2 years ago, said if it's indicated, let's do 2 baby aspirins or 162 milligrams. If somebody's in Canada and they can find 115 milligram, that's fine, but we just don't have a United States. If people have high risk for preeclampsia, then we put them on automatically. So that includes the hypertension, the pre-pregnancy diabetes, kidney issues, autoimmune issues, history of preeclampsia or adverse outcomes. When you look at the stillbirth things from ACOG, they say that you don't need to do it for prior stillbirth unless it was related to placental issues. So if the stillbirth was 1,000% not related to something vascular in the placenta, then you won't necessarily have to do it. Let's say the terrible tragedy of a motor vehicle accident, right? That would not be something that you have expected for recurrence. But I will tell you, when you look at the placentas for people who've experienced stillbirth, there's vascular malperfusion in there. This is all in a continuum. So the vast majority of people who've experienced stillbirth should be on aspirins, unless, as I said, the tragedy of a trauma led to it, because then, of course, it wasn't something that was going to happen regardless of unless a tragedy had happened. If people have moderate risk factors, more than one, they should be on it as well. And that includes, I'll read them out because there's a lot of them. First baby, obesity greater than 30 BMI, family history of preeclampsia in your mother or your sister, being of a Black race. And I'll be careful to say that it's a proxy for underlying racism. The theory being that you're more at risk for getting sicker from these things because we are not listening as well as we should. Not because Black people are more likely to have it, but as a proxy for health disparities. Lower income, probably a similar type thing. Over the age of 35, a previous history of a small baby or adverse outcome, greater than 10 years since your last baby, and IVF. And I think the list will go on and on. But basically, I think at some point we're going to have everybody on these aspirins. But that's why when you say, what can you say to your doctor? One of the things you can say is, should I be at that first appointment? Should I be somebody who should be starting this? And it's supposed to be started before 16 weeks optimally, but even has been shown to be beneficial up until 28 weeks.
Oh,
So this is something that if you miss the mark, the one visit, you can do it further on.
totally. Okay. That that helped a lot. What did that malperfusion look like on a placenta when you're
Mm,
examining them? Does it look like huge vessels, small vessels, no vessels? What are we seeing? I am
Oh,
familiar with what calcification looks like, so I'm super eager to see what you're talking about malperfusion wise.
yeah. So malperfusion can look many ways. If you think about it's similar to a heart, right? So if our heart's not malperfusing, so you can see infarctions, you can see thrombi, so blood clotting in there. You are totally correct. You can see overperfusion. So you can see hyper mature. So sometimes when placentas are not getting what they need, these villi and all these things, they actually mature faster than they should, which may run out of the gas, right? Because they're saying, I need to be as efficient as possible. We can see something called choreangiosis, where you actually get a congregation of these vessels trying to work together more. Then you can see it from the maternal side. You could also see from the fetal side evidence of this malperfusion. And so when you put these two things together, when you look at these placentas, if I see this, so for example, let's say I deliver a patient with meconium at 41 weeks, and I send the placenta. I see evidence of this. This is a patient I may say, hey, let's put you on some baby aspirin next pregnancy. I can't guarantee you that it's going to make a difference, but this is where we need to go. Whereas when we look at that placenta, especially since we know the risk of aspirin is really small, if we see infarctions, if we see hypervillous placenta maturity, all these kind of things, if we see fibrin deposition, so you can actually get scar tissue in there, when we're seeing all those things, should we be saying, how can we make this better the next pregnancy? So not just saying, oh, we have a healthy baby, but let's see, they had high blood pressure. Let's see if there's something we can do differently next time. The baby was small, but came out healthy. What can we do next time? So we don't have a stillbirth or a neonatal near miss the next pregnancy.
So if you have the hospital discard your placenta, they're not necessarily evaluating it. So how do you ensure as a patient that your placenta is being evaluated? Is it something a lab needs to do, or the doctor that delivers you will do it before they discard your placenta?
So that's a great, wonderful question. Right now, placenta pathol reports are very hard to interpret. They are very long and cumbersome. And placental pathologists, sometimes called perinatal pathologists, they're actually working on making it better. It's been almost 2 years since we changed our placental reports for my hospital system to actually explain this. Unfortunately, I think right now, with no fault of midwives or OBs, they look at the report, but they don't actually know how to interpret it. So we need to improve the education piece from it. We know to send it if the baby comes out not looking great. We know to send it for infection. We know, so there's all these reasons to send it. And I don't know that you have to send it every time. The person who comes in 39 weeks has no issues and had a completely healthy, uncomplicated pregnancy. But the patient who comes in 40 weeks and they have a couple high blood pressures, or baby comes out and doesn't do as well as you anticipated, send the placenta. See what it has to tell you, because you may learn a lot. And it's very validating for patients if they came in with decreased fetal movement and they're 39 weeks and they're worried and you say, let's induce you or anything. It's very validating if the tracing doesn't look good and I do forceps and it wasn't really what the patient wanted. When I can see that placenta and say, your baby was showing signs of not getting what they need. This placenta was running out of gas, and this is why that happened. And it's not your fault. And it can really help people as they process their birth to have an explanation of why more interventions were needed, right? So the patient who didn't want the interventions of the scalp electrode and was hoping for this minimally invasive birth, it ends up with anything but. If I debrief with them with the placental finding, it really helps them come to terms for why things happen maybe during their birth.
Totally. It gives them a little bit of closure and does
Yeah.
let them know
Validation. Yeah.
yeah, it's not my fault. Okay, why is aspirin not standard of care? Why aren't we just putting everyone on aspirin? Can you talk a little bit about the risk of why we might not be doing this?
I don't know necessarily. I think if they have no risk factors, which I will tell you, there's very few people who don't have them
That's what
anymore.
I'm thinking. Like, just American
Yeah.
culture, I feel like all of us, just like being in this society, probably
As I
low
read through
key
that
have risk
list,
factors. Yeah.
the people don't have one or more of those moderate risk factors these days. We're all having babies older, right? All those kind of things,
Yeah.
IVF, all those kind of stuff. But I think you need a universal study seeing if it actually helps prevent people with truly no risk factors. So somebody who truly has nothing that I read off to you, there's probably no benefit.
Sure.
But I'm hoping, again, research is the key. My triplets just got home from school.
Triplets, huh? How was that?
That was insane. It's funny. So people ask me all the time, like, why I do this because I'm not a lost mom.
Yeah,
And I think some of it is I just let 3 healthy kids come in the door, and
totally.
the stillbirth rate for triplets is very high.
Wow.
And it actually hasn't changed much since I had them. And I think facing that down and somehow being lucky enough to have 3 incredibly healthy babies come out of
Right.
me is such a blessing that I
Mhm.
think it was always part of it. I think the other reason why I do this work is just I've always been able to nestle in grief and be able what led to so much of this prevention, which we hadn't talked about yet, was my care for people who've lost babies. And I never knew that the care I was giving, which was very like patient focused, pregnancy after loss care, I never knew that was unusual. And I mean that 100% honesty. I thought every patient who lost a baby, their doctors called them all the time and did the things that I naturally did. And it was funny. One of my friends slash patients, she lost a twin. I delivered her healthy baby in the end of 18. And that's what started this whole journey. And she said, "Heather, I wanna go teach the Heather way." And I was like, "What do you mean the Heather way?" And she used a expletive because she makes fun of me. She's like, "You really think that everybody does what you do?" I'm like, "What, they don't?" And that led to teaching locally, and then that led to me to go to the Star Legacy Foundation Summit in 19, and that's where I learned for the first time that stillbirth may be preventable. And it has been a very interesting journey trying to get the OB community to just try. And so much of what we talked about, and I think one of the reasons why I feel like doulas are much more of the keystone at this point because so much of the message of doulas is empowerment and advocating for yourself and making sure you're being heard. And it's sad that getting my colleague to hear all the things that to doulas comes naturally in terms of how do we prevent this from happening is just not there. And I think the more that we educate patients and talk about that up to half of term stillbirths might be prevented and 25% overall, we can't prevent them all. But if a patient calls and says, I woke up this morning, my baby's not moving, and they get brought in right away and the baby has no heartbeat, they know that they weren't told to stay home. They know that they were validated and it doesn't bring their baby back, but it is so much different than what you brought up where the patient says something is wrong and a normal NST and ultrasound trumps a patient instinct that
Mhm.
something is wrong with their baby. And until we elevate that, until we let the subjective concerns of our patients over the objective data that we have to make that subjective something is wrong go ahead, or else we're not going to affect BIPOC disparities. We're not going to lower stillbirth because I think when we look at all the patients who have pulmonary embolisms not diagnosed, preeclampsia not diagnosed, or that or a stillbirth. In the so many of these stories is I wasn't validated in my concerns and my feelings. And I think that's such a key piece to all of this, which is I think why this work is also so incredibly important to me because I think when we make an effort as a society to do the pieces that we talked about today, I think we're gonna have improved outcomes for maternal mortality as well, and maternal morbidity. A patient saying, "I am sick, I am in pain," and being heard over the objective data,
Mm.
over the fact that their vital signs are stable. Fine, the vital signs are stable. They're telling you something is wrong. And just the active listening that comes from stillbirth prevention isn't just about that. It's gonna translate everywhere else.
Yeah. I just got back from the AWON conference, and that's the Association for Women's Health and Obstetric Neonatal
Yes.
Nursing for people listening being like, what's AWON? It's basically for your labor and delivery nurses, your postpartum nurses, your NICU nurses. There were all sorts of women's health nurses, anybody who takes care of you in your women's health journey. They were all there. And the theme this year, it was an unspoken theme. It wasn't like the theme of the conference, but something that I found sprinkled in almost every single talk was we have to start listening to our patients. We have to start listening
Mhm.
to the people coming in telling us about their pregnancies. We have to start listening to the Black and brown voices. We have to start listening to the people saying, something's not right. I don't think this is
Mhm.
right. I'm nervous and I don't think this is anxiety. Like, I think I'm having a gut instinct. And it was just really powerful for me because
Mhm.
you've mentioned I am new to this, and the loss community has taught me, like, I did know something was wrong and I was sloughed off. I wasn't listened to. I was dismissed. And so to hear it just again, it just drives it really drives it home that there has to be this shift that we start elevating our patients, and for us, we use the term clients' voices, because their instincts are really, really strong, even if the data doesn't back up what they're saying.
And I have a patient who, when I look at pre-implementation of this versus post, one of the stories I like to tell, so she was having her first baby and she had a marginal cord insertion.
Okay.
So we're getting an ultrasound. She was 37 and 1. And we got an ultrasound at 37 and 1 because of the marginal cord insertion, normal fluid, normal growth. The following day, she called and said, my baby's not moving as much. So 37 and 2. And she came in, we did the NST, it looked great, and she actually said, "I'm really reassured by the NST." And we had just done the ultrasound the day before, so she had the normal growth and fluid the day before, she felt reassured, nothing more needed to be done. She called me 2 days later at 37 and 4 saying that she had a little bit of bleeding, thought maybe her water broke, and that the baby wasn't moving. She comes in 37, 4 weeks, and it was the most beautiful NST you've ever seen. And I asked her, "Are you reassured?" She's, "I am not. Something is wrong." And she goes, "I don't care what on that screen. Something is wrong." And I remember sitting there and saying, "What am I gonna do? I have a
Yeah.
great NST." And then I remembered, hey, the protocol. And I was like, "Wait, I have not checked that fluid in 3 days now. Let's just see what I see." And I thought at the very least, she can see her baby moving on there and maybe that'll
Mhm.
help us get to reassurance. So I put down the ultrasound probe and she now has oligohydramnios. And we delivered her that day because indication to deliver. And it really is a marker for how the protocol was so influential in there.
Totally.
And I would like to think that I would have told her I would have done that somehow I would have figured something out. I'd like to think that, but I don't think I would. I
Mhm.
think I would have said the fluid was normal a few days ago. This NST is great. And even though I like to think of myself as a doctor who listens really well, as much as I possibly can, I think this protocol that we adapted and what I learned in 2019 from what they're doing in other countries is the reason why she has a beautiful, healthy baby potentially. And I can't say that this baby wouldn't have survived to the next day. I know
Totally.
that. I can't say this was saving the baby's life, but I can say that I was doing better active listening, that her subjective gut instinct was listened to. And she knows this. We've talked about she had a perfectly healthy baby. And the interesting is she's moved away, but the next pregnancy had no concerns. None. Like the pregnancy, the baby's moving great. She never hit a point in her pregnancy where she was worried. And it really shows that this is not something that you have over anxiety, right? This is not the
Mhm.
things that we like to blame it on. This is truly can be an individual thing, an individual pregnancy, and that the empowering and listening is so much to be gained. And as we've said numerous times on this, if we have one message to say is that if we empower ourselves to listen to try to prevent stillbirth, we're going to listen to all the other things better too.
Yeah, and that parental instinct is just so important. It's very strong. It's there for a reason, right?
Mm.
That birthing person knows. Oh my gosh, I believe in that so much. Okay, so I do have one final question to wrap us up. Why would having your first baby be a risk factor for stillbirth?
I am not sure we know the answer to that.
Wow. Are there any
Yeah.
theories? Is it because your body's
But
never done this and we're just, and it's trying to figure it out?
it could be exposure for the first time to, but I don't think we know. We know that's associated, but I don't, as far as I know, I don't think we know the reason why. Let me see if I can find that for you.
Yeah.
'Cause, and we see it's also actually a little bit more common in male, which is interesting as well.
Oh, that is interesting. Now, if
Yeah.
you have a baby that is stillborn, does that increase your risk in subsequent pregnancies of also experiencing a stillbirth?
Yes. So we know there's an increased risk. And I think, again, because cord is not the problem, it's the placenta. So
Totally.
if we're managing that next, so Tommy's, what is it called? Tommy's something. I can look it up. The UK kind of has a wonderful thing that is basically, so Dr. Alex Czel is considered one of the experts in the entire world on this subject. He's a lovely man in the UK, and he formed which is Tommy's, which basically is the think tank in the UK for stillbirth prevention and research and all those kind of things. And he started the beginning of the rainbow clinic kind of thing, which I was always organically doing, but he's the one who really started this off. And the interesting thing is, as long as he's had the rainbow clinic, he's not seen a recurrence in stillbirth for a person.
Wow.
And I think it's because of the fact that he is listening, right? The whole mark of this pregnancy after loss care is individualized care.
Mm.
It's recognizing why that stillbirth happened and maybe delivering before it happens again, right? So if I have a baby that was stillborn due to meconium aspiration at 41 weeks, I'm going to deliver the baby sooner. It's probably not going to have that. So it's an understanding of why did this happen in the first place and what can we do to prevent the recurrence of it?
Totally.
Trying to think of, oh, here, fetal factors. Let's see. It says, it talks about male. I do not see anywhere that it talks about why it's a bigger risk, something we don't know.
Yeah, that's unfortunate. It
Let's see.
really is. It's unfortunate we don't have a lot of data on this, but it is really inspiring that we've got a lot of growth. And hopefully we can bring this to the forefront of obstetricians. And it seems like we're making some good headway with our legislators. We're getting some stillbirth prevention bills passed there. So I think the wave is starting. In terms of getting this data, what would we need to see be done? Or should hospitals be asking patients if they can have their placenta and run labs on them and just analyze
Yeah.
every single placenta? Is that
Yes.
the ideal goal?
I think, well, it's a wonderful goal, but I think the first step is, so one of the things I joke around about with this community is that if you send a breast biopsy, do you ever get back the report and not interpret what it says? What we have to do is really educate providers. Like if I do a biopsy of someone's uterine lining and I don't see a term I know, I'm going to look it up, right? And I really don't think there's a single obstetrician who's not going to do the same thing. But for some reason, we see these very confusing placental reports. And I think nobody's really spending the time. So making these more user friendly, educating our residents, making sure that every family medicine, midwife, student, OBGYN resident is spending just a week or two, 1 or 2 sessions on placenta pathology and how to read the placenta report. One of the things that's really cool is residency is only 4 years. So over the course that I've been doing this, my residents are doing all the things that we want them to do. And they don't even know that it ever wasn't that way.
Mm.
I listen to them talk and they'll be like, oh, this patient came in for decreased fetal movement. Her NST looks good. The ultrasound looks good. And she's reassured. And they don't know that it ever wasn't that way. And that's the thing. And I joke around with Samantha about this a lot. We're not going to teach it an old dog new tricks. We're never going to get these 65-year-old plus people, physicians, to change their ways. But boy, can we educate the new generation, because the new generation is going to push the older generation to do more current stuff. ACOG, everybody's working hard on this medical disparities thing. They're working hard to, if we just educate better at the beginning, this is not going to be something that's an issue down the line. And we need to focus on our newest learners and graduates, and that includes teaching pathology residents placental pathology, improving the reports, making sure that a resident that comes out now, when they get a report in their box, thinks about it the same way as a breast biopsy, a vulvar biopsy, or an endometrial biopsy. And that can happen so easily because they're so ready to learn when they graduate from medical school. We just have to get them there. We're not going to get them at the twilight of their career.
I love that. I love that so much. I have this dream that I can teach residents in hospitals some of the skills that I've learned as a doula. And people always ask me, why residents? Like, why not go after the doctors that are already practicing? And I say the same thing. I say, I don't know. I feel so invigorated by the residents. They are the movers, the shakers. They're coming in. They're the new
Mm-hmm.
wave of healthcare. They're the people who are so focused on consent. And I would rather lay a great foundation with our new doctors that have
Yes.
50 years left in the practice rather than focus on someone who's going to
Mm-hmm.
retire in the next 5. And so I feel the same exact way. Oh my goodness. Okay. I feel so educated on this. I feel like I
Okay.
really have so much of a better understanding on placenta health. I didn't know nearly as much as I do now coming into this conversation. I really understand, I think, a lot more risk factors because before this conversation, fetal movement really was all I was familiar with. So it's so amazing to hear all of these other things. Is there anything else that we haven't talked about in terms of placental health, EPV, fetal movement, loss, anything that you are like, we should talk about this before we wrap up because people need to know?
I guess what I always like to remind people is this is not contagious.
Yeah. Dr. Florescue, you are such a unicorn OB. I so appreciate you being here with me today and sharing your time with all of us today and specifically doing the work that you're doing to get this message out there, encourage the research, collect these communities of mamas who are doing the work and pushing this forward in women's health. So thank you so much. If people either have experienced a loss and they want to share their story with you or get information from you. If someone's just interested in learning more about what you're doing, the research, if people have questions and want to connect with you, where can they do that?
So really the best way is via the Instagram thing. So at Dr. Frescue OBGYN, I do ask, I always happy to hear a story of a baby who's died, but I don't give personal medical advice for obvious reasons. I need to know the whole story to be able to do that. But many people around the world have shared with me their stories, and I would read your story, I will respond to you. And I going on to websites such as the Star Legacy Foundation, Count the Kicks, and Push for Empowered Pregnancy is a great way to get some resources on the subject, or Tommy's, as I talked about in the UK, all have really good resources, and read about the Saving Babies Lives Care Bundle and Measure the Placenta, all the things, all that stuff is on there. But read about these protocols and sit down with your doctor and talk about your placental health for your individual pregnancy.
Absolutely. Oh my gosh. Thank you. Truly. Thank you so much. All right,
No
y'all.
worries.
I will see you in the next episode. Be sure to follow Dr. Florescue on social media, and you can find me at Tranquility by He and at the.birth.lounge. Until next time, head to your app store and download the Birth Lounge app for evidence based childbirth education and data driven postpartum support delivered straight to your phone. Bye. Thank you so much for tuning in today. I love hanging out with you, and it is an honor to be your go-to gal when it comes to preparing for your baby. If you've enjoyed today's episode, please leave a 5-star review and tell others why they should be listening to the Birth Lounge podcast too. You deserve to have a birth that you love with a provider that values your autonomy and respects informed consent without all the trauma that you so commonly hear about on social media. New episodes air every Wednesday and Friday. Hit that follow button so you never miss an episode. I'm HeHe, and this is the Birth Lounge Podcast.